discuss the treatment with the patient when you're suggesting biopsy. The patient has to know what is going to entail, what comes afterwards. So let's look at the treatment and we'll speak about the complications. If one of the types of treatment is removal of the prostatectomy. But when this is done, the patient may have erectile dysfunction. The patient may have an inability to control urine, requiring a Foley catheter. The patient may have to wear incontinence briefs. And incontinence briefs are what we call in Dominica diapers. So you take a 55-year-old male who has prostate cancer, remove his prostate, he may be left with erectile dysfunction, he may be required to have a Foley catheter for life, or wear incontinence briefs. That's a conversation that has to be had with the patient before doing the biopsy so that they may know what it entails. Okay, second treatment, hormonal treatment available for an oncologist. Radiation treatment is available for prostate cancer. It's unavailable in Dominica, but I'm told that patients are sent to neighboring islands to get this done. Radiation therapy may also cause incontinence of stools, meaning passage of stools without being aware of it or without being able to control it. This would also require incontinence briefs. Radiation therapy may also cause erectile dysfunction. Prostate biopsy has, of course, a few complications: infection, bleeding, and slight pain. What are the downsides of a PSA that caused the British government not to recommend screening for PSA? PSA can be produced normal tissue with no cancer present. Cancer can be present, but the PSA is normal. There are other conditions that may cause elevation of the PSA in absence of cancer, such as inflammation or infection of the prostate. This is the most important one. Some cancers are slow growing. They may take 15, 20 years without causing any problems. That's some prostate cancer talking about, prostate cancer. This is referred to as overdiagnosis. But we are unable to determine which cancers are slow growing and which cancers advance rapidly just by performing the prostate biopsy or by staging. This, as you can imagine, will cause a lot of psychological stress, especially if you go through all of this, and who knows, no cancer may have been present, or you go through all of this, you do the PSA, then you do the biopsy, no cancer present. Think of a 55-year-old male who has his prostate removed, and we don't know whether that because of prostate cancer, and we don't know whether that cancer would have killed him in a few years, or he may go to 80 years of age and not have problems from that cancer. We just don't know. Of course, we err on the side of caution, and we would advise that prostate to be removed because we cannot tell whether that prostate cancer is going to spread within a few years, or it may take 15, 20 years and cause no problems. So let's sum it up. Black male, 40 to 70 years of age, you perform DRE and PSA every 1 or 2 years. If it's normal, come back next year. If DRE is abnormal, PSA elevated, then you repeat PSA to confirm, proceed with biopsy and staging after the pros and cons discussed with the patient. If biopsy is positive, then treatment options will be discussed with the patient by the surgeon or the oncologist. If biopsy is negative, then return to annual PSA screening and DRE check-in. The surgeon may decide to repeat the biopsy. After 70 years of age, testing, if any, would depend on the patient's health status, risk factors, and patient desire for further testing. Questions? I turn it over to you, Dr. Benji.
Yes, you were speaking of you spent about 20 minutes talking about prostate cancer, right? And I know you have a number of topics to cover, but this probably is your biggest topic. Can I say that?
Yes.
Wonderful. Any questions from the audience? Mr. Lawrence, Dr. Lawrence would prefer to answer questions as they occur to you rather than come later on with the same topic. Hello?
Yeah.
Anyone speaking, please unmute your mic.
Hello?
Yeah, go ahead. Who wants to ask a question?
Yeah, Dublin. Quickly.
Yes.
I think it might be useful for Dr. Lawrence to maybe get the statistics maybe later down of Dominica, because we have observed quite an increase in prostate issues and increase in awareness too, because a lot more people are going to check it out. What probably would be the advice in terms of, let's say, 40 and over? How frequently would you have to go and check it, even though you feel no symptoms or not?
Yeah, thank you very much for that question. Let me say that every male over 30, before 30 as well, but every male, every woman before 40, and especially over 40, needs to have a doctor you're comfortable with. You need to have a primary care doctor you can speak to, primary doctor you can discuss issues with. I believe that any male between 40 and 70 years of age needs to have the prostate check annually. Any male between 40 and 70 years of age needs to have his prostate checked annually. It is very, very important, and this is my recommendation. There are a lot of prostate cancer cases in Dominica, a lot of cancer cases in the Caribbean, and I believe that we can perhaps do better.
What's the point of testing every year? What's the benefit
It's
of testing?
It's 1 or 2 years. My thing is this: if, for example, remember we just said that the PSA can be elevated, can be not elevated, and the person has prostate cancer. There's a slight chance, there's a minimal chance of that. So hopefully, if last year you did the examination, doctor didn't feel anything, a PSA, and there's cancer there, and it is very, very small on the DR, it was not felt, and the PSA was normal this year. Hopefully, by next year, that PSA will start creeping up. And you cannot be lucky that every year the PSA is going to be low when you have prostate cancer. This is your best bet against a disease that is affecting males, a lot of males, a lot of Black males, both in the U.S.
How good is the prognosis?
It depends on yes, that's a very important question. If the prostate cancer is caught early and you are willing to do the surgery, undergo the radiation or whatever the case is, then, you take the cut out the prostate gland, throw it away, and it has not metastasized or spread to other organs, the prognosis is fine. Even if, again, I'm being very cautious with my terms, that's why I said refer to oncologist. Even if the prostate cancer has spread, in some cases, there's medication available. Again, of course, this is not inexpensive, but there's treatment and there's some life expectancy, even if the prostate cancer has spread to a few bones. Again, this is not inexpensive. But the prognosis is excellent if the prostate cancer is caught before it has spread.
Dr. Lawrence, thanks for your responses so far. Basically, you have another 3 minutes before Dr. Robinson come to speak. So if you wanted to spend the next 5 minutes talking briefly introducing 1 or 2 other points, I'd be very happy to have you. Otherwise, Dr. Robinson speaks and then you come back later on.
You said 5 minutes?
Yeah, it is really 3 minutes, but I could go 5.
No, I will need at least 7 minutes.
Well,
okay.
Let Dr. Robinson come in now, and then you'll come and do your 30 minutes and use it effectively. What do you say?
Okay, let's do that.
Thanks, Dr. Lawrence, for your presentation. We go straight into Dr. Robinson's own presentation. Doctor, can you? Yes, Dr. Robinson, now you can load up your slides. You can share a video, Dr. Robinson.
Yes, thank you.
Okay.
Good evening. Thank you very much for having me. I'm Dr. Karen Robinson. I'm an OBGYN practicing in the Seattle area and soon enough in Dominica. I am licensed in Dominica to practice and will be sharing my skills there shortly. The topic, as you know, is preventative healthcare in women over the age of 40. Dr. Lawrence did a great job in delineating what prevention means and how it applies. And he even mentioned some of the limitations of screening, like overdiagnosis and additional procedures. So the goal is for knowledge application. When we go through the slides and we discuss the content, we have to take some things from it to apply to our daily lives. That is what is hoped. The content in this slide is not intended to replace the decision making of your doctor or nurse. Medical diagnosis and treatments are complex interplays for which your health team has been trained. Presented here is simplified information designed to empower you to have more substantial discussions with your health practitioners. So sometimes you may say X leads to Y, but it's not that case in every patient. And so that is why you need a healthcare practitioner to go through your disease process. Primary prevention healthcare is very accessible to us as Dominicans. We have a robust primary healthcare system. Information here should also serve to empower you to make the necessary life changes to become an even healthier version of yourself. And here we go to our best health. Can we prevent disease? As Dr. Lawrence went through, yes, it is obvious we can prevent disease. It's not always easy in terms of absolute prevention. And I think he mentioned that we cannot stop necessarily disease, but we can take necessary steps to alleviate the effects of disease. And in this presentation, we'll go through various body areas, including your nutrition, gut health, physical activity, cardiovascular health, brain health. We will not touch on dementia, but I just wanted to put that in there, that is part of prevention in women. We can take necessary steps to improve or delay some of these disease processes. Bone health, fall prevention, I believe Dr. Lawrence will also cover that. Cancer prevention, breast, cervical, ovarian, and dental health is so very much overlooked, and unfortunately will be a little overlooked today. But I wanted to remind us that dental health is a significant factor in our overall health. So we're going to explore general health, blood pressure, and glucose screening. General health screening starts with a thorough physical exam. This exam should be targeted based on age, sex, and risk factors. It is not necessarily a head-to-toe examination. Various life decisions may help prevent disease, like nutrition choices and exercise. Screening for disease by your doctor is one prevention strategy which may help identify early changes within your body. Early identification may allow you to adjust your life situation to prevent disease. You may avoid certain disease foods if you have determined with your doctor that there is something already starting to affect your kidney. You may not have kidney disease, but you have identified some changes, and by changing your diet, you can stop or prevent those changes. So that is one example of why preventative care is very important. The it aims to preserve our quality of life. Visiting the doctor at least annually is recommended if you've had no previous health concerns. You may need more regular visits if you have had any health condition. Many can access the district clinics, hospital clinic sessions in Dominica, and many of us know our community health persons to seek them out as needed. And as I said, we have a very robust system, and we should encourage each other to access it. There's a lot of non-communicable disease states in Dominica, and it's getting worse, and we need to continue to address it robustly. Blood pressure and glucose screenings are important for all women, including pregnant women over the age of 40 who are at risk for hypertension and diabetes. Cardiovascular disease prevention. Cardiovascular disease is disease affecting the heart and blood vessels. Sludge builds up in the arteries and can slow the blood down. The blood carries oxygen to the areas in your body where it's needed the most. And when this slowed or delayed oxygenation occurs, there may be resulting heart damage and damage to the brain, for example, when you have a stroke. You can have poor circulation in the feet if there's poor blood flow, poor oxygenation. And of course, as you know, that can affect your quality of life. This group of disease, cardiovascular disease, are the leading cause of death in women. It's one of the leading causes of death. The number one globally is lung cancer. I'm trying to get my picture away so that I can see my slides. Okay, there we go. Other disease like diabetes, high sugar. I've learned that some of us don't know it as diabetes, but I have to say sugar to explain to some of the elderly. Smoking, high blood pressure, including previous complications in pregnancy. These can more than double the heart disease risk in women. So these diseases that I've just mentioned, diabetes, smoking, high blood pressure, can double the heart cardiovascular risk in women. Negative hormonal shifts can also amplify cardiovascular disease risk. Example, a disease condition known in gynecology as PCOS, where you have a great imbalance of the female hormonal environment and causing a great shift in metabolism and affecting the cardiac system. Cardiovascular disease prevention, again, there are prevention strategies like diet modification, smoking cessation, blood pressure management, diabetes management, obesity prevention, physical activity. So an increase in physical activity can help to delay or subdue progression to more severe disease. It's important to avoid a sedentary lifestyle, and we greatly underestimate the benefits of sleep. We'll touch just a little on that a bit later. Lipid abnormalities. We pretty much are what we eat. What we eat matters. We can have increased deposits of fat around our organs, and that can affect our quality of life. Alcohol intake, we should try and avoid. It directly damages the heart muscle, increases inflammation, and can lead to weight gain and insulin resistance.
Okay, now I hear in the voice.
Are we good? So, as a general information, Black people in the US are 30 to 54% more likely to die from heart disease. There are all sorts of reasons for that, including socioeconomic status, poor access to healthcare, and discrimination. We have been in Dominica approaching that trajectory with an increasing number of us with non communicable disease, perhaps due to poor nutrition, lack, making the wrong choices. Uh, there's a increase or difference in lifestyle. Right now, with us, we have a lot more vehicle access, so we do less walking, so less exercise, and we have primary health care, but we do also fail to access it before something starts to take place in our body. What does that mean? Prevention and screening. Very important. Recommended screening interval, if you've had for cardiovascular disease, it's recommended that you screen every 3 to 5 years. So you go to your physician annually or every 3 to 5 years. You have a relationship with your doctor, nurse, healthcare team in the districts, and you get tested for evaluated physical exam and tested with blood tests for things like lipids, cholesterol screening. Elevations in these markers can increase your risk of cardiovascular disease. We'll also touch on various facets of screening of other disease that may have direct implications for cardiovascular disease later on, like obesity. Your doctor can calculate your risk based on you having other disease, your alcohol consumption, your family history, and they may opt to shorten the time interval between these screenings. Aspirin. Aspirin is a controversial thing that we've had and we've been discussing for several years now. We've done several studies, and it looks like studies are still fairly limited in information, although it looks like the aspirin may reduce the risk of heart attack by dissolving blood clots that may form in the arteries, and these arteries may have fat deposits. Hypertension. Hypertension or high blood pressure is diagnosed if the blood pressure is greater than 130/90 on varied occasions. So it's not just one time, it's a repeat abnormality. We used to say 140/90. The recommendation is now to consider 130/90 as a value for diagnosing high blood pressure. Although Black men may get high blood pressure early in life, on average, Black women have a faster progression of disease overall. This may be due to hormonal changes and the effects on the blood vessels. There are complications, of course, of high blood pressure: early death, stroke, quality of life changes, heart complications, kidney disease, leg disorders. High blood pressure is a leading cardiovascular cause of death, especially in the Caribbean. Apparently, we have one of the highest rates of high blood pressure in these Americas, on this side of the world. Why is that so? We should reassess our lifestyle choices, our close proximity to what would be called, I guess, the Western diet, our American diet, and the decisions we make concerning all of that. We need to take a step back to reconsider what is important for us. With increased life stresses, poor sleeping habits, anxiety, depression, all these may contribute to the long-term destruction related to high blood pressure. Screening is recommended yearly if you are age 40 and over. Um, Patients with a relationship with a doctor. This has actually been studied, and it has been shown that if you have a relationship with a healthcare provider, your overall mortality is decreased. You're less likely to die from this disease, and you're likely to, because you're likely to be diagnosed earlier. You seek care early, you're diagnosed earlier, and interventions can start. High blood pressure in pregnancy. I was told I could talk about pregnancy a bit because women over 40 can still get pregnant. The average age of menopause is age 52. For us on this side, it may be decreasing slightly. On its own, pregnancy itself increases the risk of high blood pressure. Changes in the placenta and hormones affect the mother's blood vessels. This may result in sudden increases in blood pressure, which may affect the life of the mother and her baby. Certain pregnant groups are at higher risk. For example, a mother with her first baby is at higher risk of developing blood pressure changes. We don't understand everything related to this pregnancy complication of high blood pressure. Patients with a previous history of high blood pressure also have an increased risk of high blood pressure in pregnancy. So outside of pregnancy, if they've been diagnosed with high blood pressure, they have a higher chance of developing complications in pregnancy related to blood pressure. An age greater than 35 years old increases that risk, and also diabetes. Screening is important. We start at the prenatal visits, which are critical to the mother and the baby, spending less time ill overall and in the hospital. Blood pressure checks, history of symptoms, and physical exams are done at every visit. Lab work can be added if abnormal findings. This helps to catch disease progression early. Blood pressure disease in pregnancy can lead to seizures and death. It is important, and the progression it's not a gradual progression. 1 minute you have a perfectly healthy mom, or seemingly so, and the next minute she's terribly ill. So it's very important for those screening visits to not skip your healthcare visits in the clinics, and it's important not to delay care with home remedies, for example. This is my marker to stop. I don't know how fast I've gone through the slides right now, so this was my marker.
You have done well. If you are finished, I'm sure we can take questions, and then Dr. Lawrence can get some more time. So, so thank you very much, Dr. Robinson, for your presentation. We followed you very well. You seem to have a number of topics that you want to cover.
I'm sorry, probably too many. It was overwhelming and exciting at the same time.
That's good. That's good. That's good. I'm sure the audience would love to follow up on a few things that you said. So the floor is open for questions. I saw your list of questions, and you mentioned brain health and mental health. You know, that's my area. Can you just tell us what's the difference between brain health and mental health? I'm not hearing you. You're mute.
I wanted to differentiate between neurological complications versus mental health disease. So
In terms
neurological.
of about 40 years, what are the two? I just want you to talk about that for me. What are the two? How do you differentiate the two sets of conditions that affects us in terms of mental health or brain health, so we can understand what you mean?
Mental health would be more of emotional conditions which affect our outlook on life in general, whereas neurological involves the discrete processes within the brain itself. However, both we because we treat with medications, you still have those processes occurring, but it's more on uh, uh, more of a obvious pathology as opposed to a macro pathology, perhaps. Help me, doctor, help me.
I suppose this is where the physicians try to distinguish between physical and mental health, because both of them are disorders
Both of
of
them
the
have
brain,
the
of the
same
head.
physical manifestations. Yes.
Yes, okay.
That's why we're able to treat them, and that's why we're able to see some of those conditions visibly. So they are similar in many ways, but the conditions vary based on the level of the processes.
Thank you.
Can I come in here, Benji?
Yeah, I thought you wanted more time for you to do a presentation.
Please do. Please save
Go right
me.
ahead. Go right ahead, Dr. Lawrence.
So when we speak about diseases which affect the pathology, as you mentioned, of the brain, the anatomy of the brain. For example, if you have a stroke, a disease that, for example, affects the arteries of the brain, it would close off, or it would damage a part of the brain physically. Now, as a response, for example, or as a side effect, it may have some emotional damage. So somebody who has a stroke has a physical part of the brain that's actually been killed. As a consequence of that stroke, that person may have depression. As a consequence of that stroke, that person may have dementia. But they could have the stroke without having dementia. They could have the stroke without having the depression. So I think that amply describes the difference between the physical damage to the brain and the emotional part that you described there of the brain, emotional pathology that we see sometimes.
Clearly. Very good, Dr. Lawrence. Any question coming from the audience for Dr. Robinson, please?
Yeah.
Yes, moderator. Can I go?
Yes, Dr. Johnson, go right ahead, please. I didn't see your hand up.
Oh yeah, my hand is up. Well, thank you very much, Dr. Benjamin, and thank you very much, Dr. Robinson, for that presentation. I'm sure that I missed most of Dr. Lawrence's presentation, but this is Dr. David Johnson, a proud Cuban graduate and former Chief Medical Officer of Dominica. The question I wanted to ask Dr. Robinson exactly, I followed the presentation, and one thing I found is that she made it quite very simple so that the ordinary person could understand and follow what she was saying. She didn't try to get too technical just for medical doctors. But Dr. Robinson, you made, in one part of your presentation, you made reference to cardiovascular screening 3 to 5 years. Could you elaborate exactly what type of screening you're talking about within that time frame, every 3 to 5 years, so that we can better appreciate what needs to be done? I seem to have missed it. It seemed to be pretty far apart, that type of screening you're talking about. So I wanted a little more explanation, or if you might choose to elaborate it in terms of what are some of the things that one should do every 3 to 5 years. Thank you.
Those screening recommendations are only for persons who have no previous history and no risk factors of disease, cardiovascular disease. Risk factors meaning personal history of, let's say, diabetes, high blood pressure, family history in a first degree relative, a close family member, strong family history of disease. That is for a person without those associations. So 3 to 5 years, for year 1, your doctor seeing you for the first time may say, okay, let's test your cholesterol. and you may have associated tests related to the cardiovascular system. Depends. We're talking about women right now, so maybe a anemia-related test, electrolytes, and lipid tests. So tests. These are tests of the cardiovascular system. Mostly, we refer to lipid testing in that regard. It's not currently recommended that EKG be a screening test for asymptomatic patients. We use that for aid in diagnosis with specific problems.
But if I may follow up,
Go ahead, doctor. Go ahead, Dr.
is that would that be age? Are these guidelines probably age related? In other words, what I'm trying to ask specifically.
Yes.
Three to
They
5
are
years,
patients over the age of 40. What's that?
Yeah, but yeah, if I
Okay.
may. What I'm asking, okay, I would assume that one between the age of 40 to 50, the frequency will be different from one between the age of 50 to 60 and 60 to 70 in terms of that, the criteria for screening within that 3 to 5 year period.
I'm not sure what we it seems like that may be the case, right? But in terms of the recommendations that I saw, I did not see that age-related difference for an asymptomatic person. Dr. Lawrence this is his field of geriatric medicine, every day, all day, and he can further delineate what he uses in his practice.
Let me just say that Dr. Robinson, again, I thank you, Dr. Robinson, for input. I thank you, Dr. Johnson, for your question. It is very difficult, and I'm being very frank here, to find a patient who is over 50, Black, with no family history of diabetes, is not diabetic, has no family history of heart disease, is not overweight. It's extremely difficult to find that combination of Black patients. It happens, it occurs, but it is very, very far and few between. It's extremely difficult to find a 60-year-old, male or female, who is not diabetic, is not hypertensive, has no family history at all of heart disease, strokes, or anything at all in the family. So the recommendations, yes, every 3 years if you have no risk factors. But that is not what we see in everyday practice.
That's exactly what I was thinking, Dr. Lawrence.
That's not what we see.
Oh.
And it's getting worse. It is getting worse. I mean, the people, most sedentary, as Dr. Robinson alluded to earlier on, our diet is changing. It is no longer the type of fish and ground provision that our grandparents ate. Our diet is changing. So yes, we are going to see, I mean, I live in the southern US, and I'm telling you, the southern diet, I mean, we see just as many Black diabetics, obese, hypertensive, just like white people, I mean, in the South. It's due to diet and sedentary lifestyle.
So
Okay.
what I do in practice, though, I individualize patients, and I say, well, what do my labs look at? Like, what are the risk factors? And what is the patient's compliance? All of these feed into how closely I follow patients.
Okay. There's room for one more question before Dr. Lawrence comes back to his second presentation. Any further question, please?
Dublin here quickly.
Go ahead, Dublin.
Yeah, Dr. Robinson, there is a saying locally that women live longer than men because they go to doctor more often. And then it's issue they go to doctor. But I just want to ask you, in terms of what are the general guidelines for women, maybe in terms of preventive care, maybe you could give some tips as to how often should they go to check a doctor, like for some, or I mean, we ask most women, do they feel anything and they run to check on it, but the general guidance in terms of self-care and follow-up with medical professionals?
For general health care, I think an annual follow-up with a doctor when you're over the age of 40 is important, and that's how you get to relay what's going on with you, relay if you have changes in your body, and then this may give opportunity for screening or diagnostic tests if there are things going on with you. In terms of screening for gynecological disease, we'll speak about that later on. Recommendations have changed in so many ways throughout the years. Annually, we used to recommend pap smears. Now there's HPV testing, and we can spread out those screening tests to several years in between, depending on what kind of test we're doing. So it depends on the lab, it depends on where you are, what kind of test you may have available to you, whether you can look at the cell directly on the test and look for any changes, or if there is any change associated with the presence or absence of the HPV virus, human papilloma virus, that is linked, the number one link to cervical cancers. So those recommendations have changed over the years. And again, we need to take patient history, age, into account when we move forward with those recommendations. A lot of these are just, okay, if you have this and this is what we recommend, but this may not be the patient in front of you. So we have to modify things based on our findings in patients. So general health, I would say every year, physical exam, listen to your heart, lungs, do blood tests as needed, breast exam, pelvic exam, and whether or not you need a pap smear, even a pelvic exam. Some saying, well, if the pap smear is negative, you may not need a pelvic exam. I do not practice like that. I believe every time I see a lady, she should have a pelvic exam annually. And I have caught so much disease on the vulva, the external part, the vaginal area, and the cervix, unbeknownst to the patient. So those are things that I recommend, taking into account the recommendations and what we've seen, and also your population. In the Black population, we have higher risk of disease overall. And there are many reasons for that. Some of the diseases are related to potential genetics or genetic changes that are things that are different, access to care, socioeconomic status, lack of seeking healthcare early, especially in men. And maybe that's the difference we see in longevity. So, yeah.
Thanks a lot, Doctor. Thanks a lot, Doctor. Your presentation time is finished. So we are going to move straight into Dr. Lawrence's final presentations. Dr. Lawrence, there was a question that came from one of these guys,
Yes.
one of these Cuban graduates who's getting older. He asked, should a PSA be conducted before prostate biopsy? I'm sure you can answer that as you move into your next presentation.
Yes. There's some, as I said, there's some schools of thought, the UK school of thought, that if you don't necessarily need to have a PSA done, because if you feel a nodule, a stone, a hard rock in the prostate, we know it's got prostate cancer. But I would still advise a PSA to be done prior to moving on, because you're going to use the PSA, especially to see what effect the treatment would have had on that person. So if the PSA, for example, is 900, you expect the PSA to fall. If the PSA is not falling, then did the cancer spread somewhere? Yeah. So yes, I would recommend a PSA to be done. Yes, thank you. There is one other question that I saw, the question that came up earlier about women living longer than men. There's another aspect to it. Yes, women are accustomed to going to doctor because they go to the obstetrician for childcare, for pregnancy, and then they go to the pediatrician for child to take the children. So they always seem to be going to doctors. However, there's another aspect to this why women live longer than men. Women live a less risky lifestyle than men. So if you look at the people who abuse cocaine, the people who drive fast motorcycles around the cliffs and fall off the cliffs, you will find that women tend to live a lifestyle less risky than men. Men tend to drink more than women. So the number of other factors that affect a man's longevity compared to that of a woman.
Thank you. Continue your presentation now.
Okay, so how do I get my screen going again? Let's see.
Same way before.
Let's see if I can this leave. Oop. Okay. Okay. Am I okay, Benji? Benji, am I okay?
Are you sharing your screen?
Okay, that's what I asked.
I'm not seeing your screen, so that's why.
Hold on.
I think I have to get out of this.
Oh, you haven't. Oh, stop sharing your screen there.
Yes, yeah, I'm trying. There we go.
Okay, you can now share, Dr. Lawrence. Are you on now?
Not yet. Hold on. Let's share.
Karen, you're no longer sharing, right?
As far as I can see,
I'm
no.
not allowed to share.
Can you see anything? I'm not sharing anything.
Dr. Lawrence, is this a sign of aging or what?
Okay, I did it a while ago, but I'm not doing it right now.
We would love to see your screen.
Oh, yeah, we're coming on. We are coming on. No, not Outlook.
In the meantime,
Okay, Dr. Lawrence, I will have to share your screen.
Okay, let's go. Let's go.
Tell me what page.
go up still. Past PSA, past prostate.
Okay, here we are.
You're not on prostate anymore. We are finished with prostate, right?
Yes, so you're finished with prostate. We're colon cancer right now.
Okay then. We're starting the presentation at 8:17. We're going to stick to the time. By 8:40, we'll be done.
Okay, let's go.
Right.
Colon cancer. This is the third most common cancer diagnosed worldwide. It is the second cause of death from cancer worldwide, seen in both men and women. It is seen it is very common in Black men and women, American Indians, Alaska Natives, and these people are at higher risk of dying from the disease compared to Caucasians. The recommendation for colon cancer screening is starting at 45 years of age until 75 in Black people and from 50 to 75 in Caucasians. Colon cancer is appearing at a younger age today. Most colorectal cancer start as a precancerous polyp and grow into cancers over 10 years or more. An important exception is in Lynch syndrome, we'll talk about that later, where a polyp tends to grow into cancer in 1 or 3 years in some cases. A polyp is a small mass that grows in the inner lining of the colon. Polyps can vary in size and can be from a few millimeters in size to several centimeters. This picture, as you can see here, hope you guys can, as you can see here, this little bulb you're seeing there is a polyp inside of the colon. Let's move on. The next slide, this you're seeing is colorectal cancer. Okay, so what are the symptoms of colon cancer? Symptoms are similar to any other digestive or many other digestive problems. Blood in the stool, bloating, unexplained weight loss, vomiting, abdominal pain, or constipation. Is there a way to reduce one's risk of colorectal cancer? Well, let's just say if you exercise 1 hour per day, it may reduce your risk by 25%. If you lower your alcohol consumption, because 3 or more alcoholic beverages a day increases your risk by 40%. Quit smoking and lose some weight may avert colorectal cancer. So how do we screen for colorectal cancer? This test, the first one I'm going to mention is the stool guaiac fetal occult blood cord. It is available in Dominica. It's based on the premise that colon cancer starts from a precancerous polyp, which secrete microscopic amount of blood into the stool. Stool is collected at home, placed on 3 cards, and sent to the lab for testing for blood. This test is simple, non-invasive, and it can be done at home and is relatively inexpensive. Again, it's available in Dominica. Disadvantage of this test is that not all colon cancer, colon polyps secrete blood, giving a negative test a false sense of security. It may detect blood from non-cancerous polyps. Some colon cancers do only secrete blood intermittently, making them difficult to be detected by this method. Medications such as Motrin or ibuprofen and aspirin, and foods like red meat, non-cancerous conditions like hemorrhoids, stomach ulcers, or even swallowed blood from the mouth or nose can give a false positive test. Any positive test leads to a complete colonoscopy, which may cause a lot of anxiety, it's time-consuming, and of course, additional cost. Okay, the second one I'm going to mention is not available in Dominica, it's not even covered by insurance in the US, but it's advertised heavily on television. It's done every 3 years. It basically is called the Cologuard, and it looks for DNA in the stool, DNA material in the stool, which would suggest a precancerous growth or cancerous cells. As I said, I just mentioned it, but it's not available in Dominica. There's something called a fecal immunochemical test, which is easy to perform. It's again another examination of stools, but in this case, it is not affected by current medications or by diet. And blood from your nose or the upper intestines cannot give you a false positive test. If abnormal, complete colonoscopy is required. There's one here which I believe may come to Dominica eventually. It's a CT colonography. It's literally a CT scan which visualizes the colon. No sedation is required, which is great, but the bowels need to be purged or prepped for the study. It's performed every 5 years. If abnormalities is found, then complete colonoscopy is required, which means having to do the prep and that is purging again. The one who considered gold standard is a complete colonoscopy. This is available in Dominica. It can be performed in Dominica. It requires purging, and it will properly prepped for this. All the stools have to be removed from the colon by that purge. It requires sedation, so it has to be in the center where they put you to sleep to have it done. When it's done, it allows the endoscopist, doctor or the gastroenterologist performing it or the surgeon performing it, to visualize, photograph, and remove precancerous lesions or polyps. These excised lesions can be sent to the lab to be studied for cancer. The endoscopist is also able to visualize, biopsy, and photograph any visible cancer, of course. So here we have the next picture here. We see the endoscopy, the doctor with the scope well, the body of the scope in the left hand and the tube in the right. It's inserted into the rectum. The patient is lying on the side. This is where it is done. There's a monitor on the doctor's right side where the lining of the colon will be seen on the monitor and screen the monitor, as well as through the scope that he or she is holding in the left hand. The scope is introduced into the rectum, up the sigmoid colon, across the transverse colon, down the ascending colon. The doctor looks for any lesions along the wall of the colon as the scope is introduced. Then the scope is slowly retrieved and taken out of the colon. And as it goes out of the colon again, the doctor looks at the walls of the colon a second time. That's a second look to ensure that there are no lesions there. When the scope, the end of the scope, on the retrieval, end of the scope gets to the rectum, the doctor flips the scope to take a look at the inner aspect of the anus to ensure there are no lesions there. If there are any lesions found, if the lesions are small enough, the doctor can excise the lesions, take the material out for study. If the lesion is too big, as I've got a patient who has a lesion, a polyp that is 4 centimeters, that will not be able to be removed by the scope. The person who has to schedule for surgery to have this polyp removed. I believe my next slide should show. Here you have the scope going after what is a polyp. You can see the light of the scope. The next picture shows a colon polyp and the scope going to remove that colon polyp. That polyp will be removed as the doctor retracts the scope, and it will be sent to the lab for study. There may be a slight bleeding there. The scope can control any bleeding that may, slight bleeding that may occur. The scope can be used to control it. Note, this is performed when a patient is sleeping. The patient has to be sedated for this procedure. Questions?
So we're dealing with cancer of the colon of the rectal region. The question would be, how common is that cancer? You said it is what? It was very common?
Yes, it is second most cancer. It is the third most common cancer worldwide.
Okay. Any question from the audience? Without questions, you can just go to the next presentation.
Okay, I want to go to another area, which is Alzheimer's disease. Alzheimer's disease is, to me, one of the most devastating non-cancerous conditions that affects older patients, in addition to strokes. I will speak about strokes if we have time for that. Alzheimer's is a condition that is a progressive loss of cognitive function, especially with a decline in memory, abstract thinking, and personality change. As I said, it is one of the most devastating diseases that affects older people. World Health Organization said that 55 million people are affected worldwide. Alzheimer's disease normally lasts about 8 to 12 years, but in some cases it may last up to 20 years. It all varies according to what part of the world one might be. It usually evolves from patients who have mild cognitive impairment, MCI, although not all patients with MCI progress to Alzheimer's disease. It is believed to be caused by development of certain aberrant proteins in the brain called amyloid beta protein plaques and tau protein tangles. I mentioned this here because the medication that's coming out, that's available now to treat those proteins that we mentioned here. So these proteins can be identified by the brain and by using PET scans and CSF. Of course, this may not be available in Dominica. The accumulation of these proteins in the brain does not correlate with the amount of cognitive loss we see in individuals. Someone may have a lot of these proteins and not be very much cognitively impaired. There are other less common dementias like frontotemporal lobe dementia, Lewy body dementias that are caused by the accumulation of other brain proteins in the brain, but this is not the subject of this conversation. Symptoms of MCI. MCI usually precedes Alzheimer's dementia. It's just mild changes in memory. You see mild changes in memory, difficulty thinking, and problems figuring out how to complete a simple task. Again, not all MCI leads to Alzheimer's dementia. Note I use the word Alzheimer's dementia interchangeably with Alzheimer's disease because they're almost one and the same. Symptoms of mild dementia due to Alzheimer's disease involve memory loss of recent events, getting lost or misplacing belongings, trouble organizing and expressing thoughts, and changes in personality. That is very early on, that is mild disease. Moderate disease, you see increasing poor judgment and deepening confusion, need help with daily activities like bathing, grooming, using the bathroom, occasional loss of bowel and bladder control, experiencing greater memory loss, undergo significant personality changes and behavioral problems like agitation, especially today in the medical field, we call that sundowning. Some individuals have outbursts of aggressive behavior, punching, coughing, spitting, biting. This is what you see sometimes in dementia, in Alzheimer's dementia. Then it progresses to severe dementia. Severe dementia would mean the person is unable to walk, has almost total loss of all the abilities. They have to be fed. Eventually, they get to the point where they're unable to swallow. Now, in my neck of the woods, one can put a feeding tube in, and that person may last for several years, but that's, of course, an ethical issue that we're not going to deal with here. Initially, you'll find that the person can yell, can shout. Eventually, they will lose that ability to shout, they lose the ability to yell. The person eventually becomes a vegetable and will die from the Alzheimer's dementia. From the Alzheimer's disease. Dementia is just, I use those both terms interchangeably here. Treatment versus cure. There is no cure known to mankind. But in Dominica, when you think of cure, we think of getting rid totally or something. Well, it's not as simple as this. There are some medications that are available for treatment of Alzheimer's disease, not cure, treatment for the last more than 20 years. I've been using it for over 20 years. Donazepam, rivastigmine, galantamine is used, one of these, not all three of them, one of these, by themselves or in combination with memantine, which is available in Dominica. Memantine is used as standalone treatment in vascular dementia, but that's a different conversation. So, what do these medications do? And this is where it gets very technical. Does it prevent the patients from worsening? Perhaps it does. Why is that important? If a person is unable to speak, none of this medication will help the person to regain the ability to speak. If the person have quit walking, none of this medication is going to regain the ability to walk again. But what these medications can do is that, remember we said that you have an early stage, you have a middle stage, and you have a severe stage. So if the medication is started in the severe stage or the middle stage, perhaps it may slow the progression to the subsequent phase. So what it means, if you have your wife, your husband, your grandma, or your grandpa who can walk, can recognize you, can hold your hand and sustain a conversation, the conversation may not make sense, they may not know what they're saying, but at least you can actually hold your loved one's hand and have a conversation. Most family members would like to have that for as long as possible. Rather than the progressing to the severe stage where they don't recognize their family members, they need everything done for themselves. And as one patient told me recently, his wife was a believer in God, And now she has dementia. She has no communication with God. She cannot praise her God. She cannot pray to her God. There is no connection with, at least that's what he thought. There is no connection, as far as he's aware, between his wife today and the God that she loves so much, because Alzheimer's disease took that communication, the ability to connect with her God, away. So these medications may perhaps help us to help the patient to retain whatever little function, whatever little cognitive function they have. May help. I say may because, as far as I'm concerned, these medications may work for about 3 years after they don't work as well as they did before. But at least it gives the family members something to hold on to. There are two newer products, which these products have been available from since COVID. These products were not on the market from before COVID. I mention them here because this is where the treatment of this disease is headed right now. They only got approved in Europe in 2025. Lecanemab and donanemab. They are used in mild cognitive impairment and mild Alzheimer's dementia. They are only used in select hospitals and infusion centers because they have to be administered by the veins. They do not stop the disease process per se. They do not reverse the cognitive function that has been lost. All they do is help to retain whatever is there. So they are called anti-amyloid antibodies. They decrease the amount of amyloid bodies in the brain, but they do not reverse the cognitive loss that's been there. My major problem with these medications, why I don't sound very enthusiastic about these medications, is that they have a major problem. They cause brain hemorrhage. You have to be doing serial MRIs looking for the brain hemorrhage over an extended period of time, because the brain hemorrhage could be quite significant. And to me, it's very, very hard to take someone who has mild cognitive impairment and to give them a medication that may cause them to have brain hemorrhage. How to prevent or slow dementia? I was asked this question recently at a function of Dominicans. So what the literature is showing, first of all, you got to keep yourself active. Keep active, that's one thing. The second thing, you got to keep your blood pressure under control. But one of the most important things is that you maintain and foster social connections. So if you're a widow, and your son or your daughter in France and your grandchildren are in Australia, and you're living alone, it's advisable that you join a church group, do something, go play, join a domino club, do something that fosters and maintains social connections. This seems to help. The other thing that seems to help is keeping your brain active. Read, play chess. There's some board game that requires you to use your brain. Go teach, tutor some school child. Do something, volunteer somewhere, do something that keeps your brain active. These are the things that we know may help to prevent or slow the dementing process. Questions?
Dr. Lawrence,
Yes.
you've spoken in the neck of where we are right now in Dominica and around the region. Our challenge, we hardly think of reversing dementia because of the little chance that's happening. Can you talk to us about people who are in their 60s with mild cognitive impairment and are preparing for the late stage of dementia, but they're still capable of doing some things? What are the most important social activities they can do or plan with their family to manage and prevent complications in later life?
If they can afford, I will put them on the Nisopril. That is
No, I wasn't speaking of medication.
okay. Okay.
I wasn't speaking of medication. I was speaking about socially. How do they engage their families? How do they protect their families?
I'm not sure. I'm not the family you need to protect. To me, it's the patient. The person who has to be protected. If the person is mild, as the person is the patient who has to be protected, and the families have to be educated as to what to expect, or where it is going to go. And we went to the stages. Okay, they're going to increase. They're going to lose their ability to control the bowel and bladder. Someone has to bathe them. Someone has to dress them. They're not going to know whether it's going to, what type of clothes to wear to go outside, and what kind of clothes is appropriate for inside. What kind of clothes is appropriate to go to church, and what is not. Someone has to guide them through all of this. We need to expect that eventually the little infrequent wetting themselves is going to get worse. So you're going to need to stock up on incontinence breast because it's going to get worse. The person is going to need to be changed. As it gets worse, the
Dr.
person,
Lawrence.
yeah.
Our yes, Dr.
As
Lawrence.
it gets worse, yes, go on.
Our Yes We Care program and our community life is prepared to deal with our parents when they develop these problems. I was speaking about the inability or the difficulty to make decisions for themselves and what they have to put in place
Okay.
to protect their families.
Okay.
That's what I'm
Yeah,
talking
okay.
about.
Now,
Families will take care of them.
Yes. Now I get your bench. Now I get your question. Sorry for that. Okay. At some point in time, the person's judgment is going to become impaired. At some point in time, the person's judgment is going to become impaired. Well, I'm not sure it's a matter of taking care of them or taking care of other matters. Someone in the family has to step forward to make decisions on that person's behalf. That is why we have to ensure that the person, even before they get to that stage, that they either choose someone to represent them before they get to that point where they cannot make decisions for themselves. Sorry. So here's an important example. If the person has a bank account with $1,000 on it, and the person loses the ability to make decisions about $1,000, who makes that decision for them? They don't have a will. That even if that's in a will, the person's not dead yet, so the will does not kick in here. In other countries, people have what you call a power of attorney. They give financial power of attorney to someone who would take care of the financial business if they become incapacitated and alive and cannot make decisions for themselves. So the family may have to get together and decide, even before the person becomes incapacitated, as to who is going to make decisions for that person.
Thank you, Dr. Lawrence.
There's something that's been called a living will that comes into place when the person is unable to make such decisions for themselves. So let us suppose the person runs a store in Marigot, and the person is unable to make decisions about that store. What happens to the store? The person has 9 children. All nine children cannot run the store. So a decision has to be made by that person. In case I become disabled, my eldest son would be responsible for running the store or not. And so those things are made, those decisions, that information would be in a living will. It's not the same as the will when a person dies. When a person dies, that store may divide or sold, etc., etc. But who takes care of the person's financial or the business? All of this could be addressed before the person, and perhaps we need to start thinking of such things before we get to that stage. Sorry, Benji.
Thanks.
Dr. Johnson.
Yes.
Well, Dr. Johnson.
Oh, yeah, thank you very much. Thank you very much. I must say, I found the two last presentations to be very interesting. And even the one with Dr. Lawrence, Dr. Robinson as well. And I'm seeing a common thread is coming up there in terms of issues related to mental health. And as Dr. Lawrence indicated, and as WHS cite as well, probably by 2030, mental health is going to be the number one burden of disease. But my specific question I wanted to ask Dr. Lawrence to your excellent presentation, and I must say before I ask my question, I love the last part you raised in terms of prevention, what the studies have been showing today in terms of trying to prevent Alzheimer's disease. But my question to you, Dr. Lawrence, are we seeing more, are we seeing earlier, sorry, I repeat, are we seeing an earlier onset of Alzheimer's disease now? Or more specifically, are we seeing Alzheimer's at an earlier age in terms of at a younger age now compared to, let's say, 5-10 years ago? What are your views on that? Thank you.
Dr. Johnson, I'm not certain it's a matter of we're seeing more. I think it's a matter of we are perhaps looking for it, and we're looking for it more than perhaps 5 years ago. I mean, I've been doing this for 20-something years, so I cannot say that I'm seeing, at least my neck of the woods where I practice, I cannot say I'm seeing more. Perhaps we are looking for it more. Doctors are more aware. Some of these topics were not even taught in medical schools 50 years ago.
Are you saying we probably what I hear you are saying, I'm probably not saying, were we just classifying Alzheimer's disease as not people before, or they are, or as crazy person? I'm trying to understand clearly what you.
I love this question because it takes.
I'm trying to understand clearly what you're saying. So basically, you're saying it's not that there are more cases or the incidence or prevalence is increasing, but rather we are diagnosing it more often, but it's basically the same for the last 10, 20, 50 years.
I love this question, Dr. Johnson, because it leads me to my next presentation. 50 years ago, we were not looking at medical problems of aging people. We were too busy trying to cure infections, people dying from pneumonias, people dying from heart attack. There are many other things. And many of our older patients want to live into 80s and the 90s, or even the late 70s. With improvement in healthcare, with improvement in science, with improvement in technology, we have been able to extend longevity as we've been seeing in the last several years. So now we are paying more attention as to what is going on with elderly people and the disease processes that affect old people. I'm telling you, in a lot of medical schools, nursing schools, they pay much attention to Alzheimer's disease and many other diseases of elderly people. So we are now putting more emphasis, and we are looking for things that women have not have looked for several years ago. I mean, I've been doing this, so I'm a geriatrician, so I've been doing this for several years. But many years ago, I mean, you can count on a hand when, which medical schools even actually speak about geriatrics in their curriculum.
I want to add something with Dr. Lawrence here. We are talking about ourselves now, and we are trying to improve the quality of our lives.
I love that.
That's why we are promoting good health and good care for Alzheimer, because we are on the verge of Alzheimer ourselves. I don't know, but that's how I see it. So yes, we are paying more attention to our own care, and we are promoting the care of people who are old, who are getting older, like we are getting old. Okay, Dr. Lawrence, I know you want to speak of other things, but Dr. Robinson is right there on the verge, and she needs to come in now. And then we'll have an open discussion after she has presented. So Mr. Several McKenzie, Karen is going to share now.
I did it. Hello. Thank you very much. Um, so this has been enlightening. We move on. Breast cancer prevention. Nutrition, you will see nutrition is very important throughout every aspect of our healthcare. It was mentioned previously, it is no less important with whatever disease that we speak about, from breast cancer to Alzheimer's to the depression, very critical in all aspects of our life, and we greatly underestimate its importance every time we put processed foods in our mouth. And also, I have to say, just as with what you were discussing, when we were taught in medical school, it was, we did have a lecture, but the details and the importance and the value that can be gained from the study of how foods interact, those were very much not taught. So we have to learn ourselves, and as individuals and as patients, we need to learn how food is processed in our bodies, what the interplay is of proteins and carbohydrates, and that is a complex discussion that I cannot go into at this time. But we need to definitely avoid processed foods. For example, if the package says potato, but it no longer looks like a potato, we probably should not eat it. We need to avoid foods exposed to chemicals when grown. For example, added fertilizers, other types of boosters, I call them. We have to avoid fatty fried foods. Some foods lean towards being estrogenic in their properties, and breast cancer cells have certain what we call markers and proteins that respond to estrogenic type foods, increasing their lethality, their growth. One example is soy. So we need to be very careful about certain foods we eat once we have an increased risk for or have abnormalities related to the breast and are at higher risk. We need to avoid red meats, sugars, refined foods, breads, sweets. Certain foods increase inflammation, those are these foods, and may change hormonal balance to increase the growth of tumors. Exercise. Exercise throughout all facets, will repeatedly mention exercise. Exercise for cardiovascular health. It may reset the hormonal imbalance and decrease inflammatory changes. We should aim for 3 to 5 hours of moderate aerobic exercise per week. An increase in weight and an increases in weight may increase cancer risk. That's a complex interplay related to adipose tissue, the cells, the fat cells that may respond and may be estrogenic also in nature when they on the cellular level, and that production of increased hormones may affect the cancer cells. And so we need to really moderate our body fat, especially the abdominal fat area. Sleep again, here we go again. Sleep comes up. Sleep is healing and restorative, and we should get at least 7 to 9 hours of sleep. The body heals itself at that time on a cellular level. Breastfeeding has been associated with a decrease in breast cancer risk if the duration is up to about 1 year. It's very important to seek healthcare at your gynecologic clinic. Get a health screen done to include relaying to your health team any symptoms, your family history, get a physical exam, breast exam, pelvic exams. There have been studies done whether self breast exams may improve the detection of breast cancers And the answer is not really. Does it mean that we shouldn't do it? We should still be aware of our bodies, aware of our changes in our bodies. So know what's normal, what's not normal. What I tell my patients, I have them go through with me, examining their breasts. I show them what to do, and so that they be maybe better able to observe, detect abnormalities, and bring it to their clinician's attention. Know your family history. This may be a strong indication of your personal risk, so your follow up and testing may need to be more frequent. What kind of tests do we do? We talked about self breast exams, and then there is the clinician exams. What your nurse is able to do, what your doctor is able to do, examining each breast. The data shows that unless you really spend some time examining the breast, um, this does not decrease the detection and survival of breast cancer. A clinician must spend between 5 and 10 minutes really going deeply into the tissue to look for and evaluate the tissue to diagnose breast changes, breast masses, in order to have a survival advantage with that kind of testing. Now, mammography and breast exams definitely do confer a reduction in breast cancer death. A mammogram, before they had radiographic mammograms, now mostly we have digital mammograms where the image gets processed on a computer screen. We have 2D and 3D imaging, and they confer up to possibly 20 to 30% reduction in breast cancer death. At age 40, all women should get a baseline mammogram. And that is if you have no risk factors. If you have a close family history, a close relative with disease, you may need to get screening earlier, up to 10 years in advance. Cancers, I think we mentioned, take several years to develop. And so we want to catch the cancer in one of its stages of development. And we test every 2 years if you are not at high risk. This has been highly controversial. The American College of Obstetrics and Gynecology has routinely recommended 1 year screening. The United States Preventive Task Force has made changes in the start of the age of screening. They were, I think, up at 50. Now they're up to down to age 40 for starting screening. And the current recommendation is every 2 years, because that when they balance the risk versus benefit of screening, that is the best medium. And so every 2 years was recommended. Generally, I believe in the globally, that is the acceptable recommendation. But realize that we may be in a higher risk population with generally denser breast tissue in the Black population, and also, again, socioeconomic factors that may, and genetic factors that may increase risk of breast cancer. But we don't have enough data to absolutely say that some of these recommendations should be changed. And so a lot of work still needs to be done with regards to evaluating risk and recommendation of testing for breast cancer. Mammogram can miss 1 in 8 cancers. I find that still, I guess one is still pretty significant for that one person whose cancer is missed. And that cancer is missed because it's so small, and it's not seen, or it's totally the mammogram is misread by the radiological team. So these things do happen. Cancers are not always that obvious. And so regular follow-up, taking into account risk factors are always important. Findings like breast pain, changes in the surface of the skin, nipple discharge, changes in the nipple direction from forward to inwards. Those are some of the signs and symptoms that we need to look for, and changes that may suggest disease. Vitamin D supplementation has been found to potentially reduce breast cancer risk. Patients who have a deficiency of vitamin D have up to a 45% increased risk of breast cancer. That's pretty significant. I think we talked about breast exams. Ultrasound is another modality. They also have MRI. I think for our lower resource needs, mammogram is where we should start with screening. I generally add ultrasound in younger patients because mammogram is designed to detect abnormalities in the older patients. There is a difference in the structure of how the breast tissue looks. There may be increased density in varied populations, and so increased density decreases the detection of cancer. So we want to use mammography in the older patients and ultrasound in the younger patients if there's a suspicion, depending on the age, depending on the complaint, and the findings on physical exam. Sometimes we may need to go straight to mammography. I'll give you an example. In the postpartum period, I would use an ultrasound if there was a mass because the tissue has changed. And also in pregnancy, we'd use an ultrasound for initial evaluation, but that's diagnostic and it's not really screening. Ultrasound helps more in diagnostic. It's not a major screening tool that reduces survival. Breast cancer prevention, again, there are other screening modalities. I was just going through that. Sometimes we aim to prevent breast cancer by placing some patients on certain drug regimens. So again, family history, findings on exam, tumor, no tumor, type of tumors, previous history of breast cancer. There are certain medications that we can use to decrease the progression of the disease, the incidence of the disease, and hence increased survival. Early diagnosis is important. Screening, therefore, may decrease our overall risk of dying from breast cancer. Surgery is another thing that we can use for prevention. There are various aspects of surgical interventions that may be preventative. For certain types of breast tissue abnormalities, after initial biopsies, we may perform surgical removal of tissue to decrease risk of the disease progressing. So you've gone to your doctor, you've diagnosed a mass, they've done a biopsy, the pathologist has read it as abnormal cells of a certain type, and depending on the size, depending on the type, you may choose to have the complete mass fully excised. That is both diagnostic and preventative. Preventative from progressing to breast cancer. Surgical removal of the breast may also be opted for in some patients. Sometimes we have access to genetic testing, or we have a very, very strong family history of patients in our family at a young age who have been diagnosed with breast cancer. And you say to yourself, it's affected every single aunt of mine, including my mother, and I do not want that risk. I do not want to worry about breast cancer. I do not want to give it a second thought again. I'm done with childbearing, if that had any effect on your decision at all, and I want my breast removed, and you make a decision, preventative, to remove your breast tissue. That is a personal decision, and again, family history and genetic markers may help in making that decision. I need 1 second, please. Oops. Other cancers, ovarian. It's important to see a doctor early for changes in health. Symptoms may include nausea. We're talking about ovarian cancer here. Symptoms of ovarian cancer may include nausea, vomiting, weight gain, weight loss. We need to assess the family history, assess need for imaging, physical exams to identify masses, and do abdominal and pelvic exams. We don't have really recommendations for screening as we have discreetly for mammograms, like an imaging test. We do not have recommendations for doing imaging, or do we know how often we should do pelvic exams in certain populations to diagnose or attempt to diagnose ovarian cancer. It's one of the more silent killers in the gynecological pathologies. Ovarian cancer is very difficult to diagnose in most patients until it is rather advanced. And that's unfortunate because it can progress fairly quickly also. Again, cancers take years to diagnose, to develop, but ovarian is a difficult one. And by the time you've diagnosed it, it can be far advanced. Pelvic exams, when you do a pelvic exam, you're feeling for any masses through the vagina and the cervix, but those masses may not always be obvious until they reach a certain size, or that the cells have moved from beyond the ovary into the other organs, and that's called metastasis. That is a whole different prognosis and may affect quality of life in a different way. Caught early, if that has been a blessing on a patient, you can completely alleviate most of the effects of ovarian cancer by simply removing the ovaries, the tubes, and we generally remove the entire uterus. It depends on how advanced, it depends on the size, but that is the basic surgical intervention. Testing may be based on family history of other cancers. There are certain cancers that are linked. Dr. Lawrence mentioned Lynch syndrome several times. It runs in families, and there are certain cancers that like to be grouped together. Genetic testing is available, and surgical removal of the fallopian tubes may overall decrease your risk of both fallopian tube cancer and ovarian cancer. For example, the current practice with me is if I'm going to do a cesarean section and a patient requires or desires sterility, they want no more childbearing, and instead of just tying the tubes, I will remove the entire tube. And that is a preventative step, a risk reducing step for ovarian and fallopian tube cancer. Smoking cessation. Smoking has high risk from cardiovascular risk to cancer risk. Smoking is not good on any level. That toxin changes the cells and increases risk of cell abnormalities. Certain hormonal exposures, example, in the foods that we eat, in things that we apply on our bodies, medications that we're already taking, those may increase risk of cancer. Radiation for some other treatment in the past, those can cause changes in unintended cells and increase risk of other cancers. Some medications may reduce the risk of ovarian cancer, and oral contraceptives are one type of medication. Pregnancy, and so you see a link here, hormonal. Oral contraceptives, pregnancy, breastfeeding. These are similar hormonal states that may, progestin type states that may decrease the risk of ovarian cancer. The mortality is there's a 1 in 143 chance of death. 1 in 91 patients overall will get ovarian cancer. Any questions so far?
Thank you very much. Thank you very much, Dr. Robinson. Yes, we are running out of time. It's already 10 past 9. So let's now engage the audience in a general discussion on all the topics presented, particularly the last topic that you presented, so we could decide to bring a close to our session tonight.
Oh, we are closing.
You, we'll give both of the presenters a moment to close up, but not to present on any particular topic.
Okay.
Yeah, but it's already we decided to have 2 hours of conference today, and 2 hours has expired at 10 past 9.
Understood.
So the floor is open for questions. Dr. Robinson highlighted throughout her presentation the importance of our primary care system to promote good mental health practice in Dominica and to prevent many of the diseases that Dr. Lawrence and Dr. Robinson spoke about. So, Dr. Robinson, in your understanding, how do you value the established, highly reputed primary healthcare system as a preventive tool or a tool to promote good mental health in Dominica? Do you have any comments to make on that?
I'm sorry, can you repeat?
Do you have any comments to make about our primary care system, our highly reputed primary care system, in terms of preventing most of the conditions that you and Dr. Lawrence highlighted today, or rather promote good mental health practice among our 40-year-old and above who themselves know of our good primary healthcare system?
The healthcare system was intricately developed a long time ago to cover and diagnose, help identify changes early in patients within the communities. In the various districts, we have different branches of the district medical officers and their community involvement, the nursing, the screening at the clinics. Those are practices of preventative care under the umbrella of the whole medical system. So it's been very intricately developed over the years, and has worked very, very good in helping Dominicans have access. I think access is a key thing, and it's basically free access to be able to get your blood pressure checked, to get screened for gynecologic exams, pregnancy care. These can contribute if we are open to the access, because sometimes we don't access the system to help decrease the risk of disease in the community. You have diabetes screening, hypertension screening. There is counseling related to those visits. I was privy to be able to be in some of those clinic sessions when I covered at various points and in following various doctors in my early years. So I'm quite aware of the clinic and some of the dynamics here. I'm sure things have changed over time, but the health system is, the primary healthcare system is a robust system in terms of access to doctors, and clinicians and nurses and so on. Everywhere there's been shortages. I'm not sure what Dominica is Well, I don't know the details, but I know healthcare has always had shortages. And that's one of the basic things here in the United States also. There is an extreme shortage of available clinicians to provide care for patients. And if we can address that shortage, we already have the systems in place that patients can access care and continue to develop and gain the best health that they can from a preventative status. I cannot hear you.
I have one question for Dr. Lawrence here. Dr. Lawrence, is a very important question vis-a-vis your own background in medicine. How much do you think the Dominican primary healthcare system, or the overall general healthcare system in Dominica, has
This
benefited from
meeting is being recorded.
has benefited from the training program that you undertook, having gone to Cuba and became a doctor there? How much is that background training helped you to be a geriatrician as you are today, but in terms of the preventative nature of your practice and the practice that is going on by so many Cuban graduates in Dominica right now? If you have a view on that, I would love to hear what it is.
Let me remind folks that it was not very long ago that detecting diabetes. Do you know how diabetes was detected several years ago, a few decades ago, Menchi? Let me remind folks. Okay, guess you remember. Guess you remember. You realize that ants are falling in your urine, and that was a sign of diabetes.
Getting up too many times in the night.
I'm sorry?
Getting up too many times in the night to pass urine.
Ants following your urine was a sure sign of diabetes.
Yes.
We have come a very long way from that. Then we would monitor your diabetic control by dipping a stick into your urine or testing the urine to see whether you're diabetic control. We've evolved from that because we now know, or we've known for quite a while, that diabetes damages the kidneys. So the amount of glucose, the amount of sugars in your urine doesn't correlate with what's in your blood. So your blood sugar could be 500, which is extremely high, and your urine is showing very little because kidneys aren't working properly. We have moved beyond that, and we are now doing and checking finger sticks blood sugars, doing hemoglobin A1Cs on patients right now. We have advanced tremendously in our primary care system. We have a number of things in place, and almost every nook and cranny of Dominica has access to primary health care, which is free. Fortunately, Dominica, over the last 40 years, has had, and many other Caribbean countries as well, have had the luck to have trained Dominicans in Cuba. Many of us came back to Dominica, worked in Dominica, some have moved on, like yours truly, but we have contributed tremendously to the healthcare in Dominica. I dare say, and I'm sure most folks agree with me, that the Cuban-trained doctors in Dominica, Cuban-trained Dominican doctors in Dominica play a very important part in supporting the public health system. Now, we have a long ways to go still. There are many things that we need to do at the hospital level. There are many things we need to do. But we are very happy. I mean, I remember Benji, you may not remember that. I remember Benji, and some of your listeners are going to be surprised to hear this. Do you know, I have seen, growing up in Dominica, I have seen as a kid, when people had arthritis of their knees, their huge, swollen, painful knees, I remember people putting leeches on their knees, and that was supposed to suck out the fusion from the knees and reduce the pain. If I tell some of the young people now that we use leeches in Dominica several decades ago, they're going to think that we are crazy. Today in Dominica, right now, not at the primary level, but the number of hip transplants being done in Dominica. How have we progressed in terms of our medical capabilities? From that point when I was a child, where I remember vividly seeing leeches on knees in Dominica, to now we are doing transplants, joint transplants. And this education, this training, for the most part, came from Cuba by Dominicans who were trained in Cuba. We can never negate the importance of Cuba. Dominicans trained in Cuba, Cuban assistant to the Dominican health system. We can never negate that. I don't think at any point in our history we can ever fail to recognize that as being a tremendous boost to Dominican's health system.
Thank you. Thank you, Dr. Thank you. Thank you, Dr. Lawrence. Any question to the panelists so we can give them a few minutes to just summarize what they want to say so we can bring it to an end?
There was a question here that I need to answer. Can I just answer a question that's
Go right ahead, sir.
There's a question asking what is the difference. Oh, there's a question I got asking what is the difference between Alzheimer's and dementia. Alzheimer's is a dementing illness. Dementia, let's put it simply, dementia is memory loss. There are several things that can cause memory loss. The most common one is Alzheimer's disease. Alzheimer's disease is a accumulation of a certain type of aberrant proteins in the brain. You can also get dementia from stroke. You're walking down the road, you got a stroke, you quit walking, and your memory's gone. That is the second most common reason for dementia. We call that vascular dementia, is the one from a stroke. There are other reasons for dementia. For example, if your thyroid level, that's the hormonal in the body, the thyroid gland is in the neck. If it's too low, you can have dementing illness from that. If you have vitamin B12 is too low, you can have dementia from that. You can have dementia from other brain ailments like frontotemporal lobe dementia, Lewy body dementia. There are a number of other things that can cause you to lose your memory. Alzheimer's is the one we see most frequently. Okay. There's another question I saw there about, let's see, there was something about markers. There was something I saw there about markers, cancer markers. A cancer marker is always accurate in detecting cancer. A marker is supposed to clue you in. It's not detecting anything. It's supposed to clue you in. So if a marker is positive for, say, ovarian cancer, then you go look for ovarian cancer. Until you get ovarian cancer on a sonogram and it zones you in on a possible cancer that may be there. Are they always accurate? No, but at least it gives you a clue, and that's the way I would look at it. There was one other question there. Sorry, there's one other question, Benji. Dr. Benji, there's one other question there. One more. That's final question. Establishing an advance directive. So it is in response to a comment I made about the question Dr. Benjamin had about should someone make preparations before they lose their mental capacity. In the US, there's something called an advance directive, where while you have your mental faculties with you, you leave a document that holds up in court that says that if I were to lose my mental capacities, then I appoint Dr. Benji to manage my affairs for me. It could be a wife, it could not be a wife. That type of document signed by the person before they lose their mental capacity, and it has to be signed by someone who witnesses it. Usually it could be justice of the peace, it could be anyone else who is recognized by the state. That will stand up in court. In answer to this person's question, whether they should establish an advance directive by Dominicans and in the 40 plus age group. I do not know if Dr. Benji, for example, signs a document saying that when he gets over 50, over 40, I don't know if he's over 40 yet, when he gets there,
That's
and
great.
should he lose his mental capacity, he's going to appoint Dr. Dublin to manage his financial affairs. Now, in the US, that will stand up in court if it is properly witnessed by a justice of the peace or some other person. And these are the stand up. In Dominica, I am not sure certain that it will stand up in court if you put a document which bypasses your spouse or bypasses your brother and gives that right to manage your affairs if you lose your competence. I am not certain whether in Dominica that will stand up in court. And that's why I did not mention it. I'm not certain that our legal system would allow that type of document. So that person would just say Dr. Benji would have, God forbid, okay, the person has lose the mental faculties. Somebody comes in and manages the financial and business affairs. I am not certain whether family in Dominica would sit back and have that happen, or if it would even stand up in court. And that is why I did not go there. I do not know what the legal implication of those are in Dominica. I know in the US it would stand up in court.
Thank you very much. Thank you very much, Dr. Lawrence.
Greetings, Dr. Benji.
Yes, sir.
Dublin. Just quickly, I was just browsing through Facebook and I saw an interesting article dated today, May 29th, in Cuba, where they developed a vaccine called Neuro, EPO Plus, or Neural Sim, which they seem to have done all the trials and it's making waves in the treatment of Alzheimer's. So I just wanted to note that, so it's something we can research later on and get more information, but it just shows, you know, the progress in Cuba in terms of vaccines and you know, medical science. So we have somebody who have to get the vote of thanks. So when you close up,
you can
call on the person. Yeah.
Well,
Okay.
we can bring this to an end, the question and answer. Thanks everyone for all of the, let's thank the presenters, but we're gonna have a person giving the vote of thanks. Janine, I think Dr. Janine Dublin?
Dublin McIntyre, yeah.
McIntyre. Okay. Doc?
Janine, you on?
Dublin, you can do it if Dr.
She's there. Okay. Go ahead.
Hey, good night, everyone. I'm Dr. Janine Dublin McIntyre, dental surgeon. I'd like to just, first of all, thank the Cuban Graduate Guild for this thoughtful and very timely discussion, because we know so much is happening in Dominica right now regarding the health of our both young, very young, and elderly persons as well. So I want to thank you all for coming up with this thoughtful presentation. It might be the first of many to come. I'd like to also thank our panelists, Dr. Michael Lawrence and Dr. Karen Robinson. We'd like to thank our moderator, Dr. Griffin Benjamin. Also, also Mr. Mackenzie for facilitating the Zoom link. I'd like to also thank Dr. Damian Dublin for his introductory remarks. All those who are attending, the participants, as well as our media, MO News and DBS Radio for the live streaming on the Facebook pages and also on YouTube channels. I must say the information was well received, very informative. I hope, and I would like to urge persons to make the necessary lifestyle changes, ensure that you do your screenings, ensure that you go to your doctor, do your regular visits, especially the men who tend to kind of go too late. And most importantly, the earlier you do an intervention, you always get a better prognosis where you have a better outcome. So if things are caught early, then you have a better chance of having a good outcome health-wise. So just urge and encourage persons to ensure that things are done in a timely manner. Okay, so thanks everyone again for listening and for attending.
Thank you.
Okay, good night all. Thank you very much.
Thank you.
There's more to come.
Thank you. Thank you.
Okay.
Thank
All
you,
right.
everyone.